your time.
Thank you.
Thank you very much.
Yes, moving ahead, we have next session. For this session, we have chairpersons, Dr. Brigadier T. Prabhakar, Dr. Baljit Singh, Dr. Badri Shah, Dr. James Chettimatan, and Umesh Ramtani. To begin with, in this session, we have two eminent speakers, Dr. Baburaj C. and Dr. Muralidhar Joshi. To start with, we have Dr. Baburaj C. Dr. Baburaj Chakrapani. He'll be talking on the topic pain trajectory acute to chronic, when and how to intervene. Dr. Baburaj Chakrapani.
Good afternoon. Acute pain is distressing and chronic pain is more distressing. In the pain trajectory, the transformation of acute pain to chronic pain include a lot of pathophysiology changes in the nervous system, starting from the peripheral nervous system, spinal cord, and brain. Let us discuss how and when can we intervene so that this transformation can be prevented or arrested. International Association for Study of Pain has defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Here, both sensory and emotional experiences are equally important. When you consider the physiological processes that are involved, sensory system, autonomic nervous system, circulating catecholamines, other stress response hormones, and immune system responses are involved in the physiology of pain. Acute pain is an unpleasant, complex, dynamic psychophysiological response to tissue trauma and related acute inflammatory processes. It is self-limiting and confined to a given period of time. It arises in response to tissue injury, disease, or inflammation. It serves a protective biological function that minimizes behaviors that incur risk and fosters tissue healing. Severity of acute postoperative pain is important. The rate at which acute pain resolves is also one of its key features. Actually, these two properties, severity and the resolving rate, determines whether acute pain should be transformed into chronic pain or not. This is the pain pathway, the ascending pain pathway. In the bottom of this slide, you can see the list of substances released from damaged cells like bradykinin, cations, free radicals, potassium, histamine, prostaglandins, leukotrienes, adenosine, substance P, neurokinin A, and so on. The first step in the pathway is transduction. The pain stimulus is converted into an electrical impulse and then reaches the second phase, conduction. The pain impulses reaches the dorsal root ganglion. Of course, they are transported in two different pathways. One is C and other one is A delta. The conduction is A delta is faster. From the dorsal root ganglion or DRG, it enters the spinal cord through the dorsal horn and moves up through the spinothalamic tract, passing through brainstem, midbrain, and thalamus. From the thalamus, it goes to somatosensory cortex and also to limbic system and cingulate cortex. And here the perception of pain happens. In addition to this ascending pain pathway, which is shown in red, we have a descending inhibitory pathway, which originates from the periaqueductal gray matter. It descends down and synapses in the dorsal horn of the spinal cord. There are a lot of biological compounds which are released. Two important ones are noradrenaline and serotonin. Pain has become chronic when it lasts beyond the healing of injured tissue and the related inflammatory processes. Many chronic pain conditions last indefinitely. Chronic pain syndrome is a constellation of chronic pain symptoms that do not respond to the medical model of care. A chronic pain syndrome affects the patient adversely by inducing depressed mood, fatigue, reducing activity and libido, promoting physical deconditioning, and leading to disability, which is out of proportion to the documented impairment and pathophysiology. This is just like an iceberg. What we see is the persistent pain, the complaint from the patient. But patient suffers a lot other things. Different types of pain you can see: aching pain, burning pain, cutting pain, drilling pain, dull pain, electrical pain, shooting pain, stabbing pain, numbness, the pressure sensation, soreness, stiffness of the body. There are so many psychological things coming in are anxiety, fatigue, depression, irritability, and so on. There is a type of chronic pain called as persistent post-surgical pain, PPSP. Elective surgeries are acutely painful events that can lead to chronic pain. Patients undergo surgery for a wide range of conditions, and an estimated 10 to 50% of them develop this PPSP. 10 to 50 is a big percentage. And PPSP encompasses a family of chronic pain syndromes that originated from surgical trauma. In some cases, the subjective features of PPSP may bear little resemblance to the acute post-op pain from which it stems. Example, phantom limb pain. Patient had a particular type of post-op pain, and later on he developed PPSP, and the pain may be totally different in quality as well in quantity. Normally, acute post-op pain resolves in 2 to 10 days after the surgery. IASP's classification system for chronic pain syndrome describes PPSP as a very simple definition: a persistent pain state apparent 2 or more months postoperatively that cannot be explained by other causes. It happens or it continues 2 or more months, which is persistent, but there is no explanation for, no other explanation by other causes. You call it as the persistent post-surgical pain. Phantom limb pain after amputation is perhaps the most readily recognized and best described persistent post-surgical chronic pain syndrome. Incidence of chronic phantom limb varies from 30 to 80%. PPSP after breast surgery, breast cancer surgery, is also a major clinical problem with reported incidences ranging from 25 to 60%. Studies of post-thoracotomy pain reveal that it becomes chronic in 25 to 60% of patients. Cesarean section, about 6% of patients experience chronic pain after LSCS. Regarding inguinal hernia surgery, the pain can persist in around 40% of the patients. So that means the phantom limb, the breast surgery, the thoracotomy, hernia, cesarean, all these can lead on to chronic pain, and which is known as PPSP, persistent post-surgical pain. What are the risk factors identified for this type of chronic pain after surgery? It is classified into preoperative, intraoperative, and postoperative. The preoperative factors are pre-existing pain. If patient had pain preoperatively, the chance of chronic pain is more in the post-surgical period. Women are at increased risk than men, and increased age actually reduces the risk. Probably the reduced pain perception by the elderly is the reason. Psychological vulnerability, particularly depression, and traits such as neuroticism and anxiety can be a risk factor. Some patients have a tendency to regard an aversive or challenging situation as if it were utterly disastrous. This tendency, which is termed as catastrophizing, is also a risk factor. Pre-surgical pain sensitivity. Patient was very much sensitive to pain in the pre-op period itself. There was hyperalgesia in the preoperative period, and patient may be having a poor inhibitory modulation. So they are vulnerable for subsequent chronic pain. I told you about the descending pathway. If the patient has a poor modulatory pathways, he or she is susceptible for chronic pain. Coming to intraoperative factors, surgical trauma and nerve injury, especially hernias, thoracotomies, so many nerves are injured, probably that may be the cause for the PPSP. Anesthetic technique. Whenever regional anesthesia is combined, the incidence of chronic pain actually comes down. Extent of surgery. Anatomical site, especially ear, nose, throat surgeries can cause chronic pain. Duration of surgery is also a factor, whether it is open surgery or laparoscopic surgery. The chronic pain incidence is less with laparoscopic surgeries. What are the post-op factors? The severity of acute post-op pain and the quality of pain control in the perioperative period. These two are very important, and there are some treatments related to a preoperative condition which is given in the post-op period. For example, radiation to axilla for a CA breast patient who underwent mastectomy. So this radiation can actually aggravate the incidence of chronic pain. What are the mechanisms of this pain chronification? There are peripheral mechanisms affecting the peripheral nerve system, central mechanisms which are affecting the spinal cord, and the neuroplasticity of the dorsal root ganglion is a mechanism for that. And higher centers, white matter, neuron network, all can be involved. And I already said low or dysregulation of the pain modulation. If that modulating pathway is weak, then also the pain can become chronic. And this chronification can be a sudden one or it can be a gradual one also. This slide tells you how the poorly uncontrolled acute pain is causing or leading to chronic pain. It causes something called peripheral sensitization. That means in the peripheral nervous system, they get sensitized. Sensitization means their threshold, pain threshold is lowered. A non-noxious stimuli may cause pain, touch, causing pain. You call it as allodynia. And this is known as primary hyperalgesia. The peripheral sensitization leading to primary hyperalgesia, which can result in increased wound sensitivity and prolonged discomfort. Okay, still the pain is uncontrolled, not controlled properly. The peripheral sensitization in turn leads to central sensitization. Here, the pain threshold is lowered in the spinal cord. And this is called central sensitization, which leads to secondary hyperalgesia. So incident pains are going to be more, splinting will be there, and disability is also prolonged. And this central sensitization in turn can cause remodeling of neural and glia in the whole central nervous system. The remodeling can lead on to a long-term plasticity. And this long-term neuroplasticity is putting the patient into a state of chronic pain. So sensitization happening peripherally, centrally, remodeling, all these finally ends up with the chronic pain. This slide tells you how fast the chronic acute pain is converted into chronic pain. Acute injury, of course, is going to cause nociceptor activation, which happens in seconds, no doubt about it. And there it causes transduction and also peripheral sensitization. So peripheral sensitization is something happening early. And the inflammatory mediators, it showed you a list of inflammatory mediators, prostaglandins, bradykinin, potassium, etc., etc. They are collectively called as inflammatory soup. which is actually collected in the site of injury. And this inflammatory soup has a main role in causing peripheral sensitization. Now, this leads to central sensitization. And central sensitization, an important thing which is happening is the NMDA activation, NMDA receptor. N-methyl D-aspartate receptors are activated, and wind-up phenomenon is also occurring along with. Actually, wind-up phenomenon is leading to central sensitization, which happens in minutes. Okay, still that pain continues and then results in modification of neurons and long-term potentiation that can cause altered gene regulation, altered connectivity, and cell death, which happens over hours or days and results in persistent pain, which will last for months to years. Now, something about wind-up phenomenon. See, when repetitive noxious stimuli are coming through the unmyelinated C fibers, when they reach the spinal cord, they can result in prolonged, that word is important, prolonged discharge from the dorsal horn cells. You know, dorsal horn cells are seen in the spinal cord. When the stimuli are coming repetitively from the C fibers, the dorsal horn cells are going to discharge impulses to the brain in a prolonged manner. And this is wind up. So progressive increase in the number of action potentials elicited per stimulus is wind up. Let us say 10 stimuli are coming and 100 are going up. This is wind up phenomenon. And this wind up phenomenon actually is going to stimulate our NMDA receptors and finally leading into central sensitization. The whole body is sensitized. The pain threshold goes down and patient is going to suffer from things like allodynia, hyperalgesia, and so many neuronal problems are going to happen. Now, how to minimize chronification of pain? The physiological changes during the transition of acute to chronic pain are observed at various levels, I told you, from the peripheral to central nervous system. Theoretically, if the pathophysiological changes during this transition could be prevented or reversed, we would be able to prevent or minimize development of chronic pain in practice. So, you have to think about the various levels at which this transformation is happening. And we have to think about what are the things we can do at each level so that the development of chronic pain is prevented. Early management of patients with acute pain is paramount in minimizing the risk of chronic pain development. The early management, that is very important. Probably when the surgeon puts the incision, the pain starts. Perioperative period, it continues to the post-op period. So from the point of the surgical incision till the wound is healed, you have to provide the analgesia. So it should start early. The pain management should start early. And you should also recognize the patients with a high risk of developing chronic pain. The earlier slides I told you about the different categories of the patients who are at high risk. And appropriate preventive analgesia, aiming at various levels of pain pathways, would reduce the potential risk of developing chronic pain. Earlier it was called as preemptive analgesia. Now the newer terminology is preventive analgesia. You start analgesia before the surgical incision is put, and it is continued to the post-op period till the wound healing starts. The careful tissue handling, avoidance of nerve damage, and minimal invasive surgical techniques during surgery can minimize tissue damage and potentially reduce the risk of chronic pain. And reduction of an inflammatory process may reduce the risk of sensitization in both periphery and central nervous system. Inflammatory processes. How can we reduce inflammation? Of course, we can think about NSAIDs. We can think about COX-2 inhibitors. They have been proved to reduce inflammation. And COX-2 inhibitors can also prevent the breakdown of neuromodulatory substances, and which reduces the release of neurostimulators. You know, glutamate is considered a neurostimulator. And the glutamate stimulates, release can be reduced if you give COX-2 inhibitor. So NSAIDs have a role because they are all anti-inflammatory drugs. Local anesthetic infiltration of the surgical field is another effective technique to reduce the intensity of immediate post-op pain, because no pain is conducted upstream. So local anesthetic infiltration, which is a very simple technique, is a very effective technique. Now we can think about blocking NMDA receptors with antagonists such as ketamine. Nitrous oxide is also an NMDA antagonist. Methadone. So they can reduce the pain intensity and wind up, because after wind up, the NMDA receptors are going to get stimulated and the patient is going to sensitize. So NMDA antagonists can be of use. So ketamine can be used as an adjunct to multimodal pharmacological treatment, but keeping in mind the side effects of ketamine. Adjuvants, gabapentin, pregabalin, these are drugs used for neuropathic pain. They are also having a preventive effect. And local anesthesia and regional anesthesia. And regional anesthesia is probably the best technique aiming at blocking the afferent transmission of pain signals, reducing pain sensitivity. See, the problem starts when incessant flow of pain signals reaching the spinal cord. There the problem starts. By giving regional, you are preventing the pain impulses from reaching the central nervous system. So probably the best technique is regional anesthesia, and also regional blocks which can be given and continued into the post-op period. So this slide tells you about the various levels, transduction, transmission, and also drugs. At the level of peripheral nervous system, you can use NSAIDs, membrane stabilizing agent, local anesthetic, opioids, serotonin antagonist. Transmission level, I told you, peripheral nerve blocks or plexus blocks or epidural blocks, or other regional blocks are very much effective to prevent this transmission. And the modulation can be augmented with spinal opioids, alpha-2 agonists like clonidine, NMDA receptor antagonists like ketamine. Now, functional MRI studies have demonstrated changes in the centers of brain matrix of patients with chronic pain. And these centers are mainly responsible for mood, affect, and behavior. So this picture tells you about the different centers. You can see the thalamus, to which the pain is coming from spinal cord. But there are so many other areas in the brain, like prefrontal cortex, the limbic system, amygdala, etc., etc. They are also involved in affective side of perception of pain and associative side of perception of pain. It seems reasonable to predict patients with significant psychosocial stressors being more prone to chronic pain development. So patients who are having these stressors are more prone to develop chronic pain. You can see what happens in chronic pain, what happens with a healthy brain. So all these areas are affected in chronic pain. So the pain sensitizes periphery, pain sensitizes spinal cord, and now this chronic pain is going to affect your brain also. Therefore, a biopsychosocial approach should be utilized in treating patients with a high risk of developing chronic pain. To sum up, chronic pain is a major clinical problem and worldwide that merits urgent attention. PPSP can result from a wide variety of injuries and surgical interventions. Risk of developing PPSP depends on characteristics of the patient as well as on features of the surgical procedure. Anesthesiologists, by combined pharmacotherapy and real techniques, pre, intra, and postoperatively, can limit nociceptive input and prevent pain sensitization as much as possible. Thank you.
Thank you, Dr. Baburaj, sir. So we'll be moving on to the next speaker on this session. We have with us Dr. Muralidhar Joshi. We'll be talking on interventional therapies in cancer pain. Interventional Therapies in Cancer Pain by Dr. Muralidhar Joshi.
Good afternoon, everyone. Greetings of the day. Today, I'll be sharing my thoughts about interventional therapies in cancer pain. And worldwide, everybody knows cancer is a dreaded disease, and especially people are a little scared of a painful death, which can be secondary to the cancer pain per se. This is my institution, Virinchi Hospital at Hyderabad. My department is somewhere on this particular floor. Almost entire floor we occupy the hospital. And moving on to the topical discussion today, India is staring at a cancer explosion. You all know about it. You might be reading it very frequently in the newspaper and here and there. The incidence might double or triple in the next 20 years. That's just being guessed. And people say, in fact, 1/3 to 1/5 of total world's cancer patient might be in India. 1/3 to 1/5. That's like an estimate, not a confirmed one. There are different reasons for this particular problem. It could be because population rise, lifespan rise, people live for longer time, then you tend to get all this kind of end stage problems and all. Reduced physical activity, urbanization of rural areas, and of course like unhealthy lifestyle. A lot of these things might be contributing to this kind of situation. There are certain different trends also, like in women, there is a rise in breast and ovarian cancer, like in incidence, and but of course the reduction in cervical cancer because the good screening which was done by the healthcare bodies. And of course, men, if you just look at it, there is an increase, there is a rise in lung cancer and of course reduction in stomach and renal cancer. So this incidence prevalence will keep on modifying as per the measures taken by the government or maybe whichever the society which is handling this particular kind of situations. We talk about cancer pain management. If 15% of patients with advanced cancer and pain, none of their pain is caused by the cancer itself. So this is the most important. Not that basically any pain cancer patient doesn't have to be from the cancer. It can be for different reasons. We'll be discussing about that particular fact soon. But the biggest problem challenge has been the lack of awareness about pain management is rampant from primary care clinicians to super specialists. That is the biggest problem what we're facing these days. Because unless our own healthcare professionals are not trained in handling this group of conditions, how would you expect people to get a good pain relief or good pain management option? There can be, the pain can be because of different reasons. If it can be tumor related, it can come like a visceral pain, or it can come like nociceptive pain. Visceral pain, different visceral organ probably getting invaded as a stretch of the capsule or for the interluminal distension, something like that. Nociceptive pain can be because of the erosion into the bone or nerve or the muscle, and that can be present in a different way. But again, the plan of treatment, if you talk of visceral pain and medications, are maybe interventions are different compared to the nociceptive pain, because for visceral pain, you might attend to some sympathetic and parasympathetic areas. It might get good relief on that. But for nociceptive pain, you'll have to go for mixed nerve. But if you are touching mixed nerve, you might end up with some disability like probably a motor loss or probably sensory loss, which may not be appealing to the patient. So that we should be very careful about this particular aspect. Treatment-related pain, yes, even we give the chemotherapy and radiotherapy because there can be the exposure of the body to the toxins of the chemotherapy and the medications and all. So they can end up with peripheral neuropathy or glossitis, different kind of thing. Radiotherapy can lead to nerve plexus exposure, might end up with neuropathic pain or deafferentation pain. There can be concurrent related pain in this group of patients because they continue to live like any other person on this earth. So they can still get a diabetes mellitus or maybe some kind of peripheral vascular disease causing ischemic pain and all. They can still get osteoarthritis, which is like part of the aging process. So that also they can get. So these things are all quite common in this group of patients. Some people might get decubitus related pain. That is basically you might be lying down on the bed and you might end up with a painful bed sore or osteoporosis or osteoarthritis. Many of these things can be there. So you need to be careful about what exactly you're handling, what group of patient, what could be the appropriate treatment. We think pain could be a very small component to respiratory cancer patients and all. It's not like we just look at this man's back and look at the amount of branding water has been done and all. For the heart fermentation water release he received for the sake of CA pancreas, and you can just see his back and all that. So he came for celiac pressure block, but of course, so this shows that how the common man is suffering across the globe. People think cancer pain could be as small the problem as this one. It's not like that. If you just look at it, it's as big as this one. If you just look at this particular one, it's as big as this one. So it's not a small thing as such, but it's quite big. There are different treatment options which you have, but normally we recommend multidisciplinary approach. So because basically these things come under principles of pain management. First and foremost thing is treat the cause. Always we say treat the cause. If the cancer can be taken completely in toto, nothing like it. That's the best treatment for the whatever problem he has. But unfortunately, that is not the case in many conditions. We might do maybe palliative surgery supported with maybe chemo and radiation, something kind of bridge kind of thing. We might do it and all that to salvage the situation so that patient can lead a better quality of life and all. In this situation, yes, sometimes unwanted side effects do come in and we'll have to manage them also. Second option is increasing pain threshold, which is commonly done world over. You have pharmacological options like giving opioids and all, like very popular with respect to oral morphine and maybe the dermal patches, paracetamol, or NSAIDs and all. But sometimes we use pain moderators like tricyclic antidepressants or anticonvulsants like pregabalin or gabapentin for the visceral pain. So opiates, NSAIDs are predominantly for customer we use it for the I should say the nociceptive pain, but these things, the TCS and the anticonvulsants used for the visceral pain. Sometimes we add steroids and other things depending on the compression of the nerve and other things. Of course, there are non-pharmacological approach also for same condition. So if we try physical therapy, heat and cold therapy, or sometimes we do take care of the cognitive behavioral therapy also. But most important, this group of patients, they need a constant, I should say, encouragement and all, because often they tend to end up with depression and of course, and they start getting worried. Why should come to me? Why only me? Why not others and all? So these things are going to. It's very important. We address this concern and keep talking to them. Usually, first session may be difficult, but as second, third session starts and all, they start become more subjective of expressing things. Otherwise, the third option is interrupting nociceptive, what you can call it nerve block, especially from the anesthesiologist point of view, because you have the masters in that particular area. It can allow superior analgesia and reduce opioid consumption. But only problem I told you, if you have nociceptive pain, there could be loss of motor sensory, and especially if you have neurolytic in nociceptive nerve areas and the plexus and all, person might end up with the deafferentation pain. That pain can be much worse than the original cancer pain what he had. So it's very important you select the kind of portal block you want to offer for the group of patients. Maybe if you really wanted something with nociceptive pain, probably you can still put a catheter, do a local anesthetic with some steroids and all. That's fine, but without that, it's not recommended and all. But yes, if you want to go for the the visceral plexus and all, definitely you can try neurolytic, something like maybe alcohol, phenol, or if you have radio frequency machine option also, you can try out those things, nothing like it. Neurosurgical options are also available. Application is limited by the survival of cancer patient and the skill availability. Normally, the neurosurgical things that are being offered is they do thallotomy, percutaneous chordotomy, or sometimes they do hypophyseectomy. All those things are there. Some centers in the world they practice, but by and large, many places they have given up on this particular therapy per se. The interventional therapies that are being offered can be most often we recommend them to be imaging assistance, because we have to ensure that we don't end up with a new problem by going to the wrong structure without realizing that where exactly we were going with if we don't do imaging. So different kinds of varieties, what we call it. One is non-imaging assisted intervention. Second one is the fluoroscope assisted intervention, that's X-ray assistant. Then USG assisted intervention is the third one. Then you have CT guided interventions, and then advanced pain management therapies, wherein we might use something like intrathecal drug delivery system, and we might help the patient because we load the morphine medication into the opioid pump and we insert it in the body, and the catheter will hang in the CSF subarachnoid space, so that can deliver the medication to the let's say the central structures slowly at lower concentration, that will be with less side effect and all. But we want to offer that, and the lifespan has to be there at least for 3 months and not less than that. Invasive neurosurgical techniques, just now we discussed about the thallotomy, percutaneous chordotomy, hypophyseectomy. Some centers are still practicing world over. This is an interesting procedure, as we call it as trigeminal radiofrequency lesioning, commonly used for the hedonic malignancies and all, because the hedonic area is predominantly, especially the face area, is predominantly supplied by the trigeminal. So usually we look at any malignancy in that area. If pain is throbbing, not getting relieved with medication, we might offer this kind of treatment. You can just see here the foramen over. This is an oblique view of the skull. You can see the foramen over here. That medial equilateral will have the some ophthalmic mandible. In fact, they arrange like superior to inferior. They arrange like that. So if the person has only mandibular branch affected and all this, you can go into the lateral part of foramen oval and pass in the needle there. And if you just take in the lateral, you can see that the needle comes right behind the pituitary fossa. And here you have the mastoid here. So later the needle bisects, it just has entered the skull. And you can, that's foramen oval where you're entering, you can aspirate CSF also if it's free flow. Subsequently, usually we prefer to use a radio frequency electrode wherein we can deliver temperature at a particular should say duration, like 90 seconds at 65 to 75 degrees centigrade, but not more than that, because that can lead to some kind of a charring or something like that. And that should be enough. And if you feel comfortable, only precaution you'll have to ensure is to make sure that you don't carry the bacterial flora from skin all the way up into the CSF over here, foramen over, and then that can lead to meningitis. You should be careful about what you are doing. And next one, commonly we do the intervention is sphenoparetic and radiofrequency lesions. Sphenoparetic ganglion, especially very useful for the oropharyngeal malignancies, where that dissection and all those sometimes very difficult, or might end up with deformity and all those things. You can see the needle is coming all the way up to here, the lateral part of the nose over here, and you can just see the lateral view over here. This is the frontal view, this is the lateral view. You can see inverted flower base kind of structure. Which is the ganglion lies over here. The needle has gone there. So fluoroscopy done mostly in outpatient based and all those things. So you can put in a radiofrequency cannula electrode over there, and you can burn the sphenoparetic ganglion. Almost instantly they have a good relief. So that's the advantage of doing this kind of outpatient procedure where patient can be comfortable. Stellate ganglion block, you're all aware, especially we use it quite common, especially somebody who has Hodgkin lymphoma over the shoulder and all. If somebody has been radiation and all, the plexus also get exposed, brachial plexus. So that situation we try out a stellate ganglion block, or sometimes even if it's a facial pain, atypical facial pain in this group of patients, also we offer the stellate ganglion block. It works very well. We can do radiofrequency lesion and other things quite comfortably. This is one of the rare conditions what we will not get to see that often. This is another patient of CLM. If you just look at it, this particular patient already has a growth so much over here. This is the only part of normal lung and all. So it has come to severe chest wall pain, not with medication and all those things. So then we had to put in need. You can see it over here. You can put in need for thoracic sympatholysis. Very rare conditions. We will not get to do that often. This one, the needle has come all the way up to here, and we injected some contrast and all. And subsequently, if you see contrast over here, and the person had very good relief at all. So it's very difficult. Only thing is you have to be very clear. The opposite side is the lung is the only one unit. Basically, leaving a single lung. Make sure you don't end up with the pneumothorax and all. I could take the advantage because this side there is always like an extensive spread of malignancy. I could utilize that particular part for the procedure. Now coming to the visceral part, again, this is actually quite common malignancy you might see quite often, apart from the oropharyngeal malignancy. These are nothing but the organs enclosed within the body cavities, basically. So visceral pain results from activation of pain receptors by invasion, infiltration, extension, compression, or stretch of viscera. But of course, different viscera, some are solid, some are hollow viscera. Let's see how exactly it works like that. In solid viscera like lungs, liver, and kidney, they're quite insensitive to the tumor when it's good. That's why with liver secondary symptoms, it's not painful till the capsule gets destructed. When the capsule gets destructed, then only the person feels the pain. Otherwise, the person won't feel the pain. Then you got hollow viscera, like colon and all. It is sensitive to stretch or distension. Even the tumor grows on the surface of the colon, the person may not feel at all. Only if it goes inside and that increases stretch and all those because pressure, then they might feel the pain and then they might express they're feeling the pain. So that's one tricky thing about the visceral pain. The mechanism which speculates for visceral pain, which is quite very common, is there is a suppressive receptors like high threshold receptors and low threshold receptors. I don't think they are silent receptors, but they get activated whenever, especially malignancy and all those things are happening, secondaries or maybe peritonitis and all. Local ischemia worsens stimulates these particular receptors. Local ischemia, hypoxia, inflammation activate this otherwise silent receptor. There are some triggering factors, of course. They may not be tissue injury, but nature provokes the stimulus. As I was mentioning earlier, in colon, distending the intraluminal pressure rather than the volume, that can cause the severe pain. Of course, but again, extraluminal growth. If you just look at extraluminal growth, it may not be if you apply earlier. It may not add to the pressure of the inside the colon, so person may not feel much pain about it. But of course, solid organs are the least sensitive. something I told you, liver, kidney, and all those things. Unless the capsule gets invaded, you won't feel the pain. So this is a peculiar thing about the visceral pain. It's very difficult to. It might start like if you just look at visceral pain, the symptoms and all. Just sharing with the next slide only. But if you look at the mechanism, it has been found that visceral sensory information through sympathetic and parasympathetic chain gets propagated to the CNS. And of course, that goes through the dorsal horn, lamina 1 and 5. That's where we look at percutaneous chordotomy, or for that matter, thalamotomy or hypophyseectomy. But again, there is one more mechanism also, viscerosomatic and visceral convergence also in the cortex also. So that's also there, not only spinal cord cortex also, that's also there, and difficult to understand complex, but what information available right now, that central sensitization can happen because of any other pathway that might get activated. There could be referred pain because, again, something like a tumor growing under the diaphragm, you might get a shoulder pain and all, which you know about it. Of course, that is better explained by convergence and projection theory. So again, same thing comes to central sensitization to the continuous input of firing of impulses from that area. The clinical feature, especially in visceral pain, especially abdominal thing, what we commonly see is patient complaints of vague aches or some cramps, diffuse pain, poorly localized. He says something like, I'm not comfortable. They refer to nearby non-visible structures also, the inpatient if it's happening. Autonomic reflexes, like he might feel a little bit nausea and all this, because visceral sensation, it can be quite troublesome. But sometimes it can get combined with somatic and neuropathic. If the tumor starts invading the ribs and all those other structures there, automatically will start feeling the somatic pain also. The intervention commonly offered for these group of situations, one is celiac neurolysis, predominantly offered for the mid-gut developed structures like pain from malignance of liver, spleen, pancreas, kidney, suprarenal glands, and intestines, up to 2/3 of transverse colon. Celiac plexus block works, especially secondaries in livers, some stomach malignancy, and all those things. It helps a lot. The superior hypogastric plexus neurolysis quite commonly used for pelvic pain due to tumor invasion. This is a modification compared to what we were doing earlier, intrathecal polyneurolysis with respect to the injecting alcohol or phenol. Compared to that, this is much safer without much causing any kind of bowel bladder disturbance. That's the advantage of using the superior hypogastric plexus neurolysis. Ganglion impermeability is one of the earliest ganglion discovered. It was discovered only in 1990, and very common, very easily you can do it on the outpatient basis and all. It especially useful for the perineal pain due to pelvic cancer, something like CA prostate or CA vulva and all. Perineal pain, definitely this particular ganglion impermeability makes a lot of difference. Celiac plexus neurolysis is quite commonly performed across all over the world. The 85% success rate has been defined across all studies, and it alleviated pain immediately 70 to 80% and 60 to 75% in death. So that's how it is being thought of. That results. Best results are when pain still responds to anti-inflammatory drugs. That's what is being claimed. Because subsequent to when the tumor becomes too big and all those things like advanced polycystic stage, even if you inject like 70% alcohol or phenol or another thing and all, it may not reach the plexus because it gets distorted because of lymph nodes and tumor growth and all. So if we can do it early, then probably patient can have a comfortable life as long as he's alive. And this is some of the pictures what you can see over here. And this is the patient. It's called the classical intraocular technique what we use. People are passing the needle here and the CT guidance and those in the pancreatic body. This is the aorta what you're seeing. This is the crest of diaphragm. And inject the contrast confirm. Make sure that you are not in the vessel in IVC or aorta, or you probably are not in some spinal cord and all. Confirm the imaging. Then we inject for the 70% alcohol and all. You can just see the widening of the diaphragm here. Just look at this is the crest of diaphragm. You can see that compared to this particular picture, already solution is injected. You can just see that one. Sometimes it so happens the person cannot lie down because they have a huge tumor. If you can just see over here, the tumor in the secondaries and all, you can see can't lie down prone on the stomach so that they can go to procedure because this is is done prone. Then he says I can again lie to one side. So this is unilateral celiac plexus block. You can just see about. Here we give about 10 ml of 70% alcohol on either side, and here we might give 15 ml on only one side because you're doing only on one side. This is the needle which comes here and inject contrast, confirm that you are at the desired place and perform. Yes, there are some complications you should not forget about. This is the thin rim of what is black color is nothing but lung actually. So in case you tend to go to that one, you might end up with pneumothorax. You should be careful about that one. This is how it looks, the CT and all those the contrast in the CT. And this is the You can just see in maybe lateral kind of thing. You can see the contrast almost going up to 3 to 4 vertebral body. So even if you do it at maybe T12 level and all, it can always go up to T level and also can come to L1 also. So very useful and quite useful, especially in Indian conditions, because we can't offer the very expensive treatment at this for larger population. This makes a lot of difference. Next comes the superior hypergastric neurolysis, where it is quite commonly used for pelvic pain due to pelvic malignancy, let's say cervix or maybe CI endometrium or something like that. You can use it for those group of conditions. But of course, it has less complication compared with intrathecal neurolysis because bowel and bladder will preserve. But it's less effective if extensive ureteroperitoneal and tumor is there encompassing the neural plexus. For obvious reason, if the tumor is growing up in the neural plexus, it will not be able to reach the target level. But of course, less pain relief if tumor invades somatic or neural elements. Because once tumor is, because this is only visceral pain, what would be blocking sympathetic nervous system. But here, if it invades the bone and also starts invading the other structure nearby, the relief may not be adequate. Of course, we don't test the control study as that and all. So it's the structure, the suprahypogastric. You can just look at the iliac vessel bifurcation over here, the plexus coming in both the sides, and the joining over here in front of the fifth vertebral body. It's a L5 vertebral body. I'm sorry, L5 vertebral body. You can see the plexus. So bifurcation iliac vessels. The plexus form over here. So what we do is, the way we do select when the patient kept in prone position, you can see already has a cholesterol bag here. The needle comes from here, and here we reach the retroperitoneal area in the prone position, and inject the contrast, confirm that you're not in the vessel and no other abnormal structure being troubled, and inject a solution along with probably the water 70% alcohol, water chloride, and that gives very good relief. So this is one thing you can try out. This is CT guide approach. There one more approach, the fluoroscopy. You can do this well. The needle comes from here in front of probably L5S1 junction. You can just see. Get the contrast. You can see contrast right in front of vertebral bodies over here. Of course, we have to take a lateral view to make sure you can see this particular thing. What you're seeing over here, the dark color is the contrast. The needle here. So this again gives very good relief. You can use for diagnostic or you can use for therapeutic also. Then I'll come to one of the last probably intervention which I'll be speaking today is ganglion impaired neurolysis, also called as ganglion of Walber. The procedure reported for the first time in 1990s. Quite useful for terminal pain due to pelvic malignancy. Local tumor spread can limit the spread of neurotics. No control studies as that. This is how it was when it was propagated in 90s and all those things, how it should be done and all. You can just see our L5S1, SPS3. At the sacrococccygeal junction, that's supposed to be the ganglion supposed because both the lumbar superficial come from both the sides and they come and meet somewhere on the sacrococccygeal junction. That was speculated. So if you inject contrast, you can see a goblet cell kind of thing over here. Of course, they try to modify the conventional spinal needle to reach that particular curvature and all. Look at the curvature here. How do you reach here? Retroperitoneal space and all those things. Very difficult. So they're trying to go like this and all. Of course, we have modified the technique a little bit. We go from here through sacrococccygeal junction, inject a contrast here rather than trying to put a needle, spring it in between. But don't forget, the rectum is right in front. You can see the bowel gate shadow here, the dark blue, what is that bowel gate shadow? I'll show one more picture to get an idea about it. Yeah. So this is how the lateral view looks like the sacrum and all. This is the bowel gate shadow, rectal shadow, what you're seeing. Look at the needle. Either I have to come from below or I can come from here, sacrococccygeal junction. So I use this particular technique. I'm comfortable this way. The needle comes here, inject the contrast, ensure that it is in that particular area only, not puncturing anything. Then you can inject maybe about 1.5 to 2 ml of 70% alcohol. That does wonders for the patient. So what are the advantages of neurolysis for the patient? The visceral pain cancer patient can be best managed by a combination of analgesics and interventions. There are non-analgesic benefits like limitation of side effects, improved quality of life, weight gain, because once you're not getting opioids and other things, definitely the nausea, vomiting comes down, the drowsiness comes down. You become more alert. You can participate in the family activities comfortably. Once they're comfortable, happy about it, pain relief, nutrition improves, the weight gain will happen. And as it will less sedated, alert and satisfied patients, probably they can get back to work also. Of course, sometimes repeat block may be needed with increased survival time. That is as and when the situation comes that way. Yes, there are some limitations for neurolysis also. Like the advantage that there has to be some limitations also. Most important, meaningful expectation. Expecting a advanced proliferative stage and all those things, malignancy, expecting good results are difficult. But having said we can't disown the patient, something other we have to keep trying. Earlier the better, at least patient can lead a meaningful life. That's what we try to say. Of course, limiting factor could be a technical skill availability, but that also is coming down because a lot of pain physicians are now practicing in India, so it should not be much problem these days getting help. At least in every district headquarters, somebody is practicing the other. Yes, there could be some kind of short-term relief in with the technical shortcomings. If in case if I don't put the needle at the desired position, there could be a short-term relief. A tumor or celiac plexus or presence of metastasis or plexus, very difficult to get the spread, and somatic pain second to significant peritoneal involvement, you will not get a good relief and all. So these are the limitations. If tumor widely spread and technical shortcomings, we can't do much about the situation. To summarize, a combination of medication and interventions are the best option, and they have meaningful expectation how much relief it can be. Because no block is permanent. What a block is, it might work for 8 months, 9 months, 10 months. That might be survival rate for many of the malignancy patients. Of course, earlier the better. The advanced proliferative stage may not provide good relief. Repeat the interventions if required, and no harm in that one. But most important, imaging assistance offers safety and accuracy. Look at the average lifespan of a person. Even if you want to offer intrathecal drug delivery system, make sure at least 3 months you should deliver. It costs almost prohibitive. It goes up to 5 to 6 lakhs to put a pump. It's a bit expensive. But ask yourself whether I'll be able to address the pain issue of my patient appropriately. So then that itself will be enough answer for you. Only the problem is pain management is an inexpensive treatment with variable results in different clinicians. That's one thing, because still a lot of training has to happen. A lot of people have to develop skill and all. Treatment is inexpensive, but results can be variable depending on the training process. But current protocols fail to address the pain from concurrents. If they have the osteoporosis and osteoarthritis, it's slightly still difficult. We can offer like another patient we can offer, but still we don't have much definition for the same thing. Of course, best thing you can do is continuous awareness among the clinicians and the public, and of course the policymakers about the cancer pain per se. That seems the only solution at this stage. To conclude, most important is if you can't help the patient, please do not do harm. Don't be trendsetter, trying to the first one without having good exposure or like workshop experience. Weigh the risk and benefits of what you're doing. Follow your protocol. Document the procedures. Don't be shy of taking colleagues' help if you're not sure about it, because a patient who gets into problem, definitely nobody will be happy about that. If required, if you feel that you're not able to get to the required location or the target, please abandon the process for that particular day. You can come back some other day, or maybe you can take help of your colleague also. So with these thoughts, I would like to end my lecture over here, and thank you once again for inviting me for this particular IS WEBCON hosted by the Kerala ISS State Chapter. Thank you once again. Thank you. Thanks a lot. Bye.
Thank you, Joshi sir. So now we'll be moving on to the discussion platform. Chairpersons, please note, with the interest of time, we have only 6 minutes for the discussion. So to begin with, we have Brigadier Dr. Prabhakar sir. Prabhakar sir.
Okay, I'm there. Please.
Sir. Good afternoon, Prabhakar sir.
And we have Dr. Ajit sir also with us.
Oh.
And Dr. Bhadresh sir also joined us. Sir, Bhadresh sir, please unmute yourself. And we have with us Dr. Umesh Ramtani also.
Yes, sir.
And two speakers, Dr. Baburaj sir and Muralidhar Joshi is also with us. So you can have the discussions. Kindly note we have 6 minutes, sir. Please.
Yeah. Oh, well presented, actually, Baburaj and Murali. And it's wonderful. Any questions from audience or anybody wants to? Actually, Baljit, my co-chairperson, is more related with the pain. I'm actually not a pain specialist.
Well,
Baljit.
Brigadier sir, pain is something that concerns all of us, and I don't think there is anyone amongst us who hasn't faced pain. Whether it is acute pain and chronic pain, we deal with it on daily basis. But I would like to compliment Baburaj Chakrapani for the pain trajectory that he has very nicely highlighted from acute to chronic, and he has very appropriately brought out as to what is the time to intervene. I think what's important is that we identify that yes, the conversion from acute pain to chronic pain is occurring, and if we can intervene at that particular point, that is the place, that is the time actually when we can give the patient the best benefit. And Dr. Muralidhar, well, he is a master. There he comes. The man of chronic pain. I mean, he has taught so many students, and there are so many. When you go to any part of the country, you will find a student who has been taught by Dr. Muralidhar. very nicely brought out the various chronic pain procedures and the management that he has very simply explained. It seems quite simple, but it's a different matter when you do those things. How careful you have to be with regard to these procedures. But well, that's where the master stands out, and I think he has brought out all those aspects of chronic pain management very nicely. Now, I don't think there's any question that we see here in the chat box.
No, sir. There are no questions as of now.
Yeah.
Oh, good.
Dr. Badresh,
Firstly,
Yes, sir. Thank you, sir. Really enjoyed. Both the sir, both the speaker, really nicely illuminated.
Thank you. Thank you.
It was nice to hear from the stalwarts of pain medicine, but I'm being a junior learner. I just want to ask Dr. Baburaj, sir, that what is your technique of choice regarding the preventive analgesia method during the perioperative period to avoid the chronic pain settings as you just projected accordingly?
Okay, sir. Thank you, sir. Actually, it is a combination of pharmacotherapy and regional anesthesia. Okay, you can give, I said earlier, peripheral sensitization is because of the inflammatory soup. So before the incision is put pre-op, I will be giving the drugs like NSAIDs, even COX-3, opioids, and intraoperatively before the incision, I want to give a local anesthetic through any route. It can be spinal, it can be epidural. If it is an epidural, I would be able to continue in posterior period also. So actually, preemptive means giving analgesic before incision. But that that concept has changed. Just by giving analgesic before incision is not going to prevent sensitization. So I will be continuing my this combination of renal block and pharmacotherapy intraoperatively, and at the end of the procedure, I will be continuing in the post-op post-anesthesia care unit and also in the post-op ward. Because once patient is out of your anesthesia care unit, then the patient is going to suffer from pain. So I would like to instruct my surgeons that you have to continue this analgesia for some more days. Of course, by asking the patient, you have to ask the patient, do you have pain? Because usually they assume that, okay, patient doesn't have any pain after 48 hours. So it should continue. So this is my modus operandi.
So any experience with IV lignocaine infusions during the perioperative period?
When I was working, when I was working with Rajagopal sir, actually I was with Rajagopal sir for 3 years. I saw him using lignocaine, but in medical college I had never used lignocaine infusion. I have seen sir using lignocaine infusion.
Thank you.
Thanks.
Thank you, sir. Thank you very much for this session. So on behalf of ISA WEBCON Kerala, we thank Dr. Baburaj sir as well as Dr. Muralidhar Joshi for your wonderful scientific deliberations, as well as for chairing the session. It is our duty to thank Dr. Prabhakar sir, Dr. Baljit sir, Dr. Badresh Shah sir, and Dr. Umesh Shah sir also. Thank you for joining us. Thank you, sir.
A moment
thank
to
you.
Kerala State Branch for giving us the opportunity to be here with you. Wonderful program organized, and I think on behalf of all my friends here in the panel, we thank each one of you for giving us this opportunity. Wonderful opportunity, and thanks for the privilege. Thank you so much. God bless.
Thank you, Baljit
Thank
sir.
you.
Stay safe. Take
Bye-bye.
care.
Thank you.